Thank you very much for the invite. So this session is closing the infection loop, air decontamination. So I work independently, so just my disclosures to say in the last couple of years, I've received payments from the following companies. Okay, so my learning objectives, the learning objectives of the session is to understand this relationship between hands and surfaces in the transmission of infection, and to understand the importance of indoor air quality in healthcare. We're far more aware more recently of that indoor air quality, and then to look at some of the evidence in air decontamination technologies to provide that, to provide the infection transmission mitigation. Okay. I'm seeing everyone saying good morning from sunny everywhere. So it's very sunny in Huddersfield as well. So closing the loop. We understand and we know a lot about hands and hand decontamination and hands contamination. So we contaminate our hands from surfaces, from equipment, and we can readily pass those between patients. So we know that there's plenty of evidence to say that hand hygiene is the single most effective action to stop infection. But we need to consider this circle of infection. Oh, it's a bit slow there. Right, so closing the loop again, looking at that surface and surfaces and that relationship between hands and surfaces. And I've just picked out a couple of studies that I particularly like. The one on the left-hand side is Rawlinson et al. Carried out at Great Ormond Street. So that's the paediatric hospital in London for those that are not UK based. And what they did was they took a surrogate organism that mimicked, that was similar to the coronavirus. So this was a harmless organism, I have to point out, a harmless organism. And what they did was they contaminated the surfaces of the safety rails of a child's bed in a side room. And then what they did was they watched how quickly that same organism passed to other areas in the ward. So within 10 hours, 41% of the contact points had become contaminated. So that was things like light switches, call bells, door handles, etc. So it passed out of the side room into the ward on those frequently touched points. And then a much older study on the right-hand side with Chen et al. They were looking at those frequent touch points, those hand touch contact points. They looked at 6,000 contact episodes. Interestingly, they were saying that in an intensive care unit, there was up to 93 contact episodes per hour. That's a horrendous amount of times. Almost impossible to keep decontaminating your hands if that was the number of cases, the number of episodes. So their conclusions were hand hygiene is absolutely important, but keeping the environment clean was very much important. And they talked about systems change. And I think that's about how we do things differently to prevent some of that environmental contamination and thus the hand contamination. So nice paper by John Otter about limitations of conventional cleaning. So we know that we get human error and that inconsistency, sometimes lack of ownership and who's responsible for cleaning what piece of equipment. It relies on people knowing the correct solution of the disinfectant, the correct contact time, and making sure that all the surfaces have been reached. And then we're much more aware of the automated room disinfection systems, and these are brilliant for giving high-level disinfection, but has to be in an unoccupied area. So really good for single rooms, following a patient with perhaps Clostridium difficile, or other infections. And John talked about the importance of staff compliance and that standard IPC precautions. And again, he talked about poor hand hygiene will result in higher levels of environmental contamination. So that very much that cycle, that circle of the loop. So what I want to talk about now as we go forward is that consideration of the air. So what we know is that some organisms will pass through the air, but I actually think that COVID has really allowed us this opportunity to really look at this in more detail. So when you look at the difference between droplet and airborne, we've got the airborne aerosols are suggested that they are the smaller ones, smaller than 5 microns, and the droplets aerosols are suggested to be the larger than 5 microns. And that was the way I was taught. And as Nina's already alluded to, that, I'm an old girl here, and that was how we were always taught. But the reality is droplets and aerosols are expelled in different varieties of sizes. The size, though, is thought to determine how far they travel, and that we know that the smaller droplets start to evaporate quite quickly, and then therefore they can stay suspended in the air for longer periods. And then an interesting paper by Klompus et al. Looked at the respiratory virus transmission and the potential implications for infection control programs. And he was very critical about policies that we tend to focus very much on this droplet and airborne categories, but actually he suggests, or the authors suggest, that most of the transmission actually occurs in that close contact, because that's when the aerosols are the most concentrated. So they concluded that proximity, duration, and the ventilation collectively would suggest or explain the very high transmission rates. And they suggest that the transmission rates in patient shared areas in healthcare, so in small bay areas, the transmission rates are 30 to 40% with respiratory viruses. So that's quite a huge number. So when you look at SARS-CoV-2, we've had this argument, haven't we, around droplet and airborne. Really interesting paper by Jones et al. He was looking at the social distancing, because, of course, some countries were talking about 1 metre, some countries were talking about 2 metres. And what he said was the distance of the different droplet sizes is based on very outdated evidence. And again, Stephanie Dancer, very similar, saying it was outdated, and dismissal of insufficient evidence about airborne spread of viruses is quite unscientific. And then those of you that know Professor Kath Noakes, she said that COVID is more likely to be opportunistically airborne, so when the environment, the conditions are right. Okay, so, but have we ignored the risk of airborne transmission? Because these are quite old studies. I've just picked out 4 studies which were quite interesting. So the first one is Jacopo Pulgari, if I pronounced that correctly, looking at the transmission of Acinetobacter. So he looked at, it was a surveillance study in 2 intensive care units over an 8-month period. And really interesting, they found high numbers of Acinetobacter in the air. But when they looked at the clones, they found one clone that was present in the air for 27 days, but was found in clinical specimens for up to 15 weeks after. So huge survival time in the air. So the second study is Nika et al. And they looked at gram-negative organisms, and they found that they were present in the air. They found both Acinetobacter and Pseudomonas frequently detected in the wards, particularly in ICUs and the operating theatre. Just very quickly, 2 more studies, again looking at Acinetobacter in both of these, and they found the Acinetobacter present in air samples, and they both suggested we need to do something differently, and we need to consider that how we manage the air going forward in infection control. So I'm an old nurse, so I remember Nightingale wards very, very clearly. So nice open wards, nice high ceilings, plenty of ventilation, not so good perhaps for patient dignity, privacy, and we often had very poor side room accommodation. But what we've got now is we've got change wards where we've got more compartments, we've got smaller rooms, and what you've got is that area in the middle, particularly where you've not got a lot of good ventilation. And we know that a lot of our hospital estates actually don't have really good ventilation. We've often modified old buildings with smaller compartments. So we're all aware of the hierarchy of controls, very much came to the forefront in COVID, where you look at the most effective control measures are at the top, the least effective with the PPE, etc., right at the bottom. I am certainly not saying that PPE wasn't required, because absolutely it was required. But actually what they're saying is the engineering controls were much higher and more likely to control than just PPE alone. So when you break down the hierarchy of controls and picking out those engineering controls, there is something there here around that building structure, those airflows, air changes, looking at natural and mechanical ventilation, and considering those air disinfection units and making sure we've got hand hygiene facilities. So I'm just going to just quickly go through some of these studies. So this is a nice study by Somson and Daniel Bond. So they looked at the transmission of SARS-CoV-2 in a cardiovascular clinic. And what they found was the role of the ventilation transmission is now recognised. That what they said was it was unclear whether existing building ventilation is sufficient, and maybe we need to be looking at additional air cleaners. And what they concluded was ventilation needs to be at least 10 air changes per hour. And actually we know we've got lots of old estate that actually doesn't achieve that level of air changes. Nice paper by Jemima Collins, looking at the burden of hospital-acquired COVID. And I think those of you working in acute trusts and in other healthcare environments have seen huge numbers of transmission of hospital-acquired COVID. It's more likely to affect the old and the frail. They're less likely to survive. And then once they're discharged into community, and often those elderly patients need further care and support in community. And then actually further spread happens in community. And it's more likely then that those are the people that might be readmitted to hospital. So a paper by Mark Ponson in Wales, they looked at inpatient mortality, and what they said was the nosocomial infections were consistently, the mortality was consistently higher in those that actually acquired COVID in hospital compared to if they acquired it in community and then were admitted to hospital. And nosocomial infections occurred on average 30 days after admission. So you can see here the chart about those differences between the mortality of community and nosocomial acquired. So these two charts really sort of show the hospital-acquired COVID. So the one on the right-hand side is the England and Wales data, and then on the left-hand side it is the COVID hospitalisations, and that was the Welsh data. And you can see there's much higher numbers of hospital-acquired when you look at patients that are tested 8 days or more after admission, so huge numbers. I personally like this, the RHI data from Scotland, because I think this just clearly shows the hospital onset cases. So the dark blue are the definite hospital acquired, the lighter blue are the probable, but you can see how we, in 2022, in just last year, those huge numbers, and actually if we don't do something different, we're going to get caught out again this coming winter. So then when we look at some of the technology and so supplementary air filtration on aerosols and particle matter. So this was a study carried out by Matt Butler and team in Cambridge. And it was an actual experiment because basically they'd put in an air filtration unit into a ward, and then it accidentally was turned off. So they took that opportunity then to actually measure. So it was an elderly care ward. It was a relatively small elderly care ward. They had mechanical ventilation in the central corridor. And they situated the air cleaning unit. So I think different papers talk about air cleaning, air purification, air disinfection units. I'm going to sort of lump them all together at the moment. So this was an air cleaning unit. And then what they did was they monitored the CO2 and they monitored particle matter by putting sensors into the patient bays, the single room and corridor. So the next slide, you can actually see the layout of the ward. So you can see that the blue box is where the air cleaning unit was situated, and the green diamonds are showing actually where the sensors for the CO2 and the particle matter. So all the sensors demonstrated higher levels of particulate matter when the air cleaning unit was turned off. There was a correlation between the CO2 levels and the particle matter, so they correlated. And what they found was the particles actually travelled considerable distance around the ward. And what they said was the staff movement was likely to create that turbulent waves and actually aid the movement of the particle matter between the different bays and rooms. They found that the unit actually substantially reduced the particle matter in similar sizes to respiratory viruses. And they concluded that these air cleaning units could reduce airborne spread of fungal and bacterial infections, including C. diff. So this was a scoping exercise carried out on portable air cleaning units. So what they were looking at was mapping the methodologies used to assess air cleaning units in practice. They found 24 studies. 17 of these studies were actually carried out during the pandemic, which really highlights people's interest in portable air cleaning units. So most of the studies show significant potential to mitigate those impact of those aerosols, and 5 of the studies managed to measure the association between the air cleaning units and decreased infections. So this was a nice study carried out in Turkey. I do apologise if people can hear my dog barking in the background. Sorry about that. So this was a study carried out by a team in Turkey. This was just before the pandemic. So they had 2 identical intensive care units. So what they did was they were able to have a control intensive care unit and then an interventional intensive care unit. So in the interventional intensive care unit, they actually put in the air decontamination units. So over the total study period, the colony forming units in the air and surface were found to be lower in the interventional ICU compared to the control. There was a significant positive correlation between the number of colonies detected and the rate of hospital-acquired infection. So the next slide, I'll show you the impact it had on the hospital-acquired infections. And the microorganism concentration decreased more rapidly during the first week when the air purifiers or the air decontamination units were installed in the ICU units. So here you can see the distribution rate of the hospital-acquired infections. So The solid line is the interventional intensive care unit. So you can see the first couple of months, that significant drop in cases, then it rises again as the units are turned off, and then as they swap over units, you can see it decreases again, and the dashed line is the control. So this next study was where they were looking at air purification technology, actually in a long-term care facility. So the air purification system technology was actually installed in the ventilation unit. So it was like the standalone portable units, but it was actually installed into the ventilation system, and they found significant reduction in the airborne pathogens. They also saw the reduction in the volatile organic compounds, almost a 40% reduction in healthcare associated infections, because at the end of the day, that's the most important, is we need to know that what we reduce in the air is actually preventing infections. And they saw this significant reduction in surface contamination. So think about that, that loop that we talked about, the hands, surfaces and air. If we can reduce what's in the air, clearly this study showed that significant reduction in surface contamination, which really supports that system change that Chen et al. Were talking about. And then I like this study by Fennelly et al. So this was carried out in an empty ward. So what they did was they used a nebulizer and aerosols from the nebulizer at a similar size to respiratory viruses. So what they found was the natural ventilation varied with the different atmospheric conditions. The portable air filtration significantly increased the clearance of those aerosols compared to natural air ventilation alone. And the combination of natural ventilation and portable air filtration was significantly the most effective. So if you look at the nice chart on the right-hand side, you can actually see the first bit is where the windows are open, air filtration units on. You can see that those aerosols are really low. When that's turned off, but the windows are still open, there's a rise. And then when the air filtration unit is on alone, so the windows are closed, air filtration on, it's slightly better than the windows alone. In fact, much better than the windows alone. But obviously, when the windows were closed and the air filtration was turned off, you can see that sudden rise in the aerosol levels. So what are our options if we're going to look at equipment? So there's the fibrous filter devices. So they filter all the aerosols in the air, and then you can look at the units where there's some technology, so UVC, ionizers, ion generators, ozone generators, and plasma. I'm not an expert on these, so I'm not going to try to be an expert here, but the important thing is making sure that what you perhaps select is a reputable company. How long's the company been established? Because loads of companies just appeared overnight during COVID, producing air filtration units. Making sure there's some independent testing, that there's user compatibility, and very importantly, making sure there's no additional unwanted byproducts, and consider the consumables and the running costs. So I'm nearly finished. So I just finally want to finish nice article in the Lancet at the end of May, saying it's no time for complacency over COVID in Europe. So the hospital admissions of patients with COVID does continue. Those of you that use social media and Twitter will see there's still people talking about COVID and COVID admissions. Those immunocompromised and vulnerable patients and those with the multiple comorbidities, there's still at severe risk of COVID-19. So the impact of COVID is likely to continue over the coming years. We will see another wave this winter, I feel sure. And therefore, if we don't mitigate against that, we're going to see those huge numbers again. Strategic attention and investment is needed to effectively manage COVID-19, particularly in healthcare, and improving ventilation and indoor air quality is crucial to reduce the respiratory infections. And they suggest, the evidence there suggests it to be cost effective. So before I hand back to Nina, conclusions: current hospital design generally doesn't prioritise the clean air. Our infection control policies are still emphasising hand hygiene and surface disinfection. And those of you that are in England, the national manual definitely is still emphasising those points. So cleaner air can result in cleaner hands and surfaces. We've seen that in some of the evidence I've presented, and may provide that missing link in infection prevention and control. I don't think we can be complacent over COVID-19, and I do believe that the use of air decontamination systems to improve that air quality should be part of our infection control toolbox, particularly where we've got areas of high risk of infection, those vulnerable patients, and where we know we've got poor ventilation. So thank you very much for listening.